Ladies and gentlemen, I'm talking about the F words. Because in 2019 in the UK, if my patients are fat, even a little, 40 or near to, fail to quit smoking, fail to have living children in previous relationships, fail to find a suitable partner and therefore still single, found a suitable partner but not in a heterosexual relationship, fail to live in a postcode that funds any IVF treatment, fail to fall within the 10% of population who doesn't want children, fail to fall pregnant even if they had one cycle of IVF. They are in a bit of a fix. Infertility, defined by WHO as a medical condition characterized by failure to achieve a pregnancy. The period that's defined is normally 12 months. It is a worldwide condition. It's common, affects 1 in 6 people. So if you take the number of people in EU or the world, you see 25 million, 80 million. So it's not a small problem. Causes of infertility, that's what I have to diagnose day in, day out in the clinic. Frustratingly, a quarter of our patients will never get a diagnosis because despite all the tests that we do, they fall under the X files. In other words, unexplained, no test has indicated any problems. But of course, there are those patients that have ovulatory disorders, so polycystic ovarian syndrome, they don't ovulate properly. Tubal damage, such as that caused by chlamydia, gonorrhea, sexually transmitted disorders, factors affecting male infertility, so such as previous surgery, torsion of the testes when they're young, or undescended testes, those are all risk factors. Of course, those with uterine or peritoneal disorders, so such as endometriosis, such as big fibroids, and so on. So these are the causes of subfertility. They are proper medical disorders. They're pathologies that can, most of the time, be treated, but not always. And then, of course, on your right-hand side, you can see, surely the 40s is now the new 30s. Because look, it worked for all these celebrities, right? And some of them you must recognize. I don't know if people are getting more picky, young people. I don't know, I'm a bit old, I think. People are getting a bit more picky. Maybe society, overall in many levels are changing. So even if your Tinder is always swipe left, swipe left, swipe left, you swipe up, you still swipe left, right? So it is becoming a social condition too. And this particular table really just shows you, if I was giving this talk many years ago, this number would be much lower, but of course with time, the mean age of childbirth has increased, and the number of children that each couple, each person has decreased. And this is just to give you an indication that is below the 2.1 so-called sustainable number for fertility. So what do we do as clinicians when our patients come with inability to conceive? Besides getting the right diagnosis, investigating, these are the current treatments available. Ovulation induction, that just purely means inducing ovulation. So for those people who can't produce an egg, quite simple, you can give them some simple oral medication to induce ovulation, and many of them will succeed without further intervention or treatment. But then, of course, some others may need insemination, so putting the sperm into the womb, into the uterus at the right time to assist in fertilization process. But when we talk about treatment and when you hear these being said and mentioned in the media, it's mainly around IVF, and of course IVF in addition, ICSI. or in the very long words here, intracytoplasmic sperm injection. In other words, putting the sperm into the egg to facilitate it, giving it a little bit of help. And that's usually performed if medically indicated, such as low sperm count, so on and so forth. There are other treatments that we offer, such as freezing of gametes, frozen embryo transfer, which I'll talk a little bit about, and of course donor eggs, donor sperm. But mainly we're really talking about IVF-ICSI. What is IVF-ICSI, you ask? Well, simply, if you can follow this flowchart when it starts, women will be given injections, or they give their own injections. Our nurses will teach them how to do it. Essentially daily injections and scans, a couple of scans in a period over 2 weeks or so, maybe 4 scans, 5 scans, just to see what their ovaries are doing, how well their eggs are growing. Okay? And then when the eggs are mature to a certain size, then what we would do is induce ovulation by giving the patient a different injection, and the eggs will be released. But how do we get these eggs? Well, we put them through a procedure called egg collection, usually done under sedation, but it can be done under general anesthetics. But essentially, what we do is insert an ultrasound guided procedure, ultrasound probe with a little small needle, insert it vaginally, retrieve the eggs out, and we'll give the eggs that are retrieved to the embryologist to see if the tubing has the eggs that we've collected. And you can see from this nice video, actually nowadays we can also video the development of the embryo, and that gives you a little nice time lapse of what happens in vitro, so in the lab. And you can see there that the eggs are obviously fertilized, and it's developing and dividing. And eventually you'll see a formation of a blastocyst, which is a day 5 embryo, which can then be planned to be replaced in the patient. And what happens in the replacement essentially is you put a tiny little embryo in a little catheter, and you pop it in like a smear test, but literally just put it into the uterus, and it stays there. A lot of patients ask, oh, should I not move, or should I hang upside down? No, you don't need to do that. Once in there, it's pretty sticky, and it tends to hopefully implant, and we don't have to do anything more. Wait for a pregnancy test, roughly in 2 weeks' time, and you know whether it's good news or not. Now, sometimes there may be spare embryos formed, so some of these may be extra, and what you could do is then freeze them and replace them in a cycle that is much simpler than what I've just shown you, called frozen embryo transfer, or frozen embryo cycles. But essentially, patients just literally need to take some tablets, hormonal tablets, grow the lining to a suitable level, and you put the embryo back. So in a cycle of IVF, you can see here that you create fresh embryos that you can replace, and you also can put back frozen ones if the cycle wasn't successful, if you have some frozen embryos. However, if you don't have any frozen embryos, clearly you'd have to start all over again. So there's a little bit of luck involved as well. Now, the problem, however, as we all know, and if you don't know, that's a chart there that shows how IVF is provided in England, in the NHS, and how the commissioning groups are providing this. And as you can see, most places do not fund all of what NICE recommend, which is 3 full cycles of IVF, for clear reasons, because of course if you don't have 3 cycles, the chances for success is not is not more likely. So so 3 cycles is the logical number of cycles to fund. But you can see at least most 60% here of the CCGs fund one cycle, so not the full 3 cycles as NICE would recommend. And in fact, a full cycle should be the fresh and the frozen, but many places only fund the fresh and not the frozen. And as you can see here, there's also a small number of CCGs that actually don't even fund any treatment cycles. Now, this is a 2016 fertility fairness audit data, but at that stage, there's loads of changes that's happening. Funding decrease, and a lot of the commissioning groups are already discussing then whether they should be reducing the funding for IVF provision. When I see a patient in clinic, however, there's quite a lot of confusion when it comes to, whether they're eligible or not. Because of course, in an area like Hampshire, which is where I practice, there are many, many CCGs, and they do differ in terms of their criteria. And it's the same in London, it's the same countrywide. So number of cycles, for example, some fund 1, some fund 2, some fund 3, some fund frozen, some don't. The definition of the cycles vary slightly. The age, some to 35, some to 40, some to 42. Some would define male characteristics in terms of the age, beyond 55, that's the cutoff. Others, no criteria for the male characteristic. Time of trying to conceive, sometimes 12 months, sometimes 2 years, sometimes 3 years. Previous children usually is a categorically no funding if you have any previous living children. And of course, there's a whole different number of providers in the region, which of course you have to offer the patient the choice. You can imagine the administrative nightmare I have here. It's not easy to administer, but equally, it is really heterogeneous, very, very random in terms of the eligibility criteria. And of course, only if you're in a heterosexual relationship. And if not, then virtually the funding is not there to support the treatment. So here, it just shows us that NHS funding is decreasing. And just to give you an example, Croydon in London, here we are, a decreasing or exiting funding completely, and several other regions around has cut their number of cycles from 3 to 1, from 2 to 1, and this is happening all around England. But the good news is, if you decide to move to Scotland, you might get 3 cycles if you've satisfied the criteria. And in fact, Scotland has gradually over time increased their funding, NHS funding. So has actually Wales. But of course, with the green line depicting England, it's gradually going down. I think in some ways that's fueling or has contributed to creation of an IVF industry, and majority of IVF treatment are actually privately funded, 60% in general. In some centers, they do more private, less NHS, and in others, vice versa. The sad thing and the difficulty with my job is that IVF, whilst it's a great invention and it's advanced significantly over the last 40-odd years, we still are seeing a success rate, i.e. live birth per cycle, of the maximum 30%. So you can see here in this particular bar chart, fresh cycle, good prognosis patients, essentially under 35, maximum 30%. Now, donor cycles, of course, donor eggs are from younger patients, and you should see a reasonable success rate despite the age group of the patient. So if the patient has only a 30% success rate per fresh cycle, per transfer of the embryo, that would mean majority of my patients are not going to get pregnant in the first cycle. So I see a lot of frustrated, disappointed patients after their treatment cycle. And that's just purely by how successful this technique is at the moment. I think fertility has become a commodity. I mean, you Google fertility and you see this, which is very different from 20 years ago when I was training. These adverts don't exist, but now you have a refund policy, 100% if you don't fall pregnant. You have a compareivf.com website, and so on and so forth. What's, however, even worse, in my opinion, is that because the patients are really desperate, and because the doctors are equally desperate, because there are conditions where we don't know how to diagnose, how to treat. Patients keep failing, and so there is this issue around add-ons. What are add-ons? Add-ons are, for example, non-evidence-based treatments. Add a little bit of glue. Try to hatch the embryo a little bit earlier. Give it a bit of antibiotics. Steroids, perhaps. Bit of supplements here and there. Anything simple to something perhaps even more complicated like IV immunoglobulin treatment, so on and so forth. Some potentially complications can be encountered. And I think this is all because we are desperate, both clinicians as well as patients. And this is what happens. Patients are exploited in some ways to pay for these add-ons, and unfortunately still fail. And this is where I don't wish IVF will go in years to come, right? It really breaks my heart when patients say, look, there's no hope for me now, I'm going to give up. And they've only had one cycle because they say, look, this is not working. They wish that IVF never been in their life because the burden of having IVF treatment was so bad. So they've given up, right? And that really doesn't give our field any good reputation at all. So I've painted a rather bleak picture. Do we have any solutions? How do we get ourselves out of this pickle? Well, I'm no politician. I'm a mere clinical professor doing my job. But this is what I think perhaps could change. It may take time, and maybe not all the solutions, but these are some suggestions, which some are already in the pipeline, some are being, discussed, consulted. I think, if IVF NHS funding is provide the adequate number of cycles to treat patients. How do you achieve that? Well, we need a nationally regulated, agreed price range. But the answer is, I suppose, not to push the price bracket down so much so that actually commercially it becomes non-viable, because we are then at risk of creating a two-tier premium and a low-cost basic treatment, and that is ironically the worst outcome we can have. So I think there need to be a conversation, a negotiation with private providers and any providers of NHS, nationally agreed, so that our patients can get the good quality care that they deserve. And of course, we need regulations on add-ons, right? It's not as you wish, but new technologies need to be put through the usual research rigor so that it's not just quack medicine that we practice. Medical advances, that's what I'm good at doing, and I think it needs to move into the digitally focused area because that's what the era we are in now. And we need to support and fund paradigm-changing innovations that will prove clinical benefit. And I'm here, so I'll talk about my two pieces of research really, really quickly. One of it is a number of years now we've been trialing, and we will do more trials around this personalizing care using an app. So simple, cheap, so that we can track the emotional signature of our patients. So neglected very much, we're focusing so much on the medicine, we forget about the person. I think something like that with a proven paper version research that has proven it helps with just translating it into the digital era. And I'm hoping with more trials that comes out funded by NIHR, MRC, we'll be able to achieve this, to be able to help manage the mood while patients are waiting, while they're anxious, remind them about the complicated medical timeline that they have to cope with, and of course supply them with tips on how to cope and how to support themselves during this very complicated period of their time, their treatment. The other invention that I'll talk very briefly on is this particular invention that we've been working in Southampton for a number of years now. And it is essentially from the concept of we don't actually know what happens in the womb. The womb is a black box. How do you monitor it? There's not much we can do to monitor it in real time. And so we've invented this little gadget that's in trial, preconception real-time monitoring with a wireless, batteryless device so that we can personalize the data, we can inform the doctors, inform the patients what interventions are necessary, and then be able to change the outcome, perhaps without the need for IVF, or perhaps being able to triage them to treatment at a much earlier stage. Of course, this is at trial, and as I say, we need to go through the usual research rigor in order for this to then be used in our patients, hopefully changing the paradigm of diagnosis and investigations. And with that, I thank you.